Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson and your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we're live, I wanted to remind everyone that while we don't take questions over the line, you all have the opportunity to type your questions into the question box at any time. I'll check periodically for questions throughout the session, so please don't feel you need to wait until the end of the presentation to start typing your questions. Go ahead, put them in as you think of them. I'd also like to let you all know about an event upcoming. Children's Healthcare Canada is hosting in partnership with Alberta Children's Hospital and Alberta Health Services. This specialized event, All In, Creating Synergy in Pediatric Complex Care in Canada, will welcome over 200 administrators, frontline clinicians, patients, and families. And the focus will be to showcase and share practices that we know are working to help support children with complex healthcare needs and their families. And registration for this event is now open. Today, we're joined by colleagues from BC's Children's Hospital and Solutions for Kids in Pain, SCIP, to bring you the elephant in the room, diagnostic uncertainty in pediatric chronic pain. As many of you know, SCIP is a knowledge mobilization network, one of the networks of centers of excellence, working to bridge the gap between existing evidence-based solutions in patient care. And SCIP is co-led by Dr. Christine Chambers at Dalhousie University and Doug Menard, Associate Director here at Children's Healthcare Canada. Today's webinar is related to the diagnostic uncertainty in pediatric chronic pain, which affects 1 in 5 youth and is associated with high societal and economic costs. Many young people with chronic pain don't receive a diagnosis that explains the pathological cause of their pain, and a major challenge that youth and their parents face is the uncertainty regarding diagnosis, prognosis, and treatment. I'm delighted to welcome our speakers today. Alexandra Neville is a PhD student in the clinical psychology program at the University of Calgary under the supervision of Dr. Melanie Knoll. Her research is first to explore the phenomenon of diagnostic uncertainty with youth with chronic pain and their families and clinicians. And Dr. Tim Oberlander is a physician scientist who works to bridge developmental neurosciences and community child health. He's a developmental pediatrician and works as the medical lead for complex pain service at BC Children's Hospital. For those of you on Twitter, please tag us at Children's Healthcare Can and at Kids in Pain. And it is my pleasure now to pass the mic over to Alex.
Good morning. I'm Alex Neville, and I'm so excited to be here today and so excited to be joined by Dr. Tim Oberlander, who has spent 25 years working with the children who we'll be talking about today, children with complex chronic pain. And together we're going to talk about chronic pain in children and diagnostic uncertainty in this context. And we're going to do this in a few parts. So we'll give an introduction of chronic pain and diagnostic uncertainty for those who don't know. We'll share and discuss research findings about how diagnostic uncertainty is experienced by youth and parents. And we'll discuss this among clinicians and really focus in on the clinical encounter. And at the end, we'll leave you with some take-home messages that we hope will be meaningful to everyone listening. So Tim, I'm really excited to have the opportunity to talk to you today because you've been a clinician for over 25 years working with these youth and families. I wonder if we could start with what you see as the greatest challenges in assessing and treating complex chronic pain in children, and what is it that we're talking about when we talk about chronic pain in children and youth?
Alex, thanks so much for inviting me to join you in this important conversation. When we think of chronic pain, we typically define it as something that lasts more than 3 months, but in reality, it's really much more than that. For most children, painful experiences are short-lived, and yet for others, pain persists long after the original injury. Somewhere between 15 and 40% of youth report chronic pain that markedly reduces the quality of their life. For many, this leads to more pain, limits to daily activities at home and at school and in the community, and has a significant impact on their lifetime. Chronic pain in children is a complex condition that's influenced by many other factors that bring in links to poor mental health, internalizing behaviors, and related mental health disorders such as anxiety and depression. But it's much more than just the tissue damage that might occur at the outset. Factors like sex, age, previous pain experience, family background, and social environment all play an incredibly important role in the developmental origins of chronic complex pain conditions. The child's developmental context also plays a role. Their cognitive, social, and behavioral characteristics are now known as key determinants that shape the presence of the painful condition and even the response to treatment. And therefore, we have to bring in an integrative and adaptive approach to pain management. One of the things we know is that our toolbox in managing pain is pretty big, and we usually have lots of diagnostic and treatment options that actually do make a difference for many children, youth, and families. But sometimes they don't, and then we're stuck with this awful problem called therapeutic failure. You know, what to do when you get stuck? You've tried everything, and nothing seems to work. And so we're left with a really deep question: why does good treatment fail?
Absolutely, and that must be very difficult as a clinician. What do you know about why that happens?
Well, it sometimes happens for a combination of factors, and they're not all relevant to each child or family, or they all don't operate at the same time. But to some degree, each of these following that I'm going to present have a role to play. So the first is that there can be some confusion about what do we really mean by chronic or complex pain. Is it that we don't agree that pain is really present, or that other disease processes are more important than just symptom management? Also, for children who have developmental disabilities that limit communication, cognition, and motor abilities, our ability to access the pain experience can sometimes be very challenging. And that brings us to this whole question about whether we can actually assess pain. Is there a pain thermometer, or is there a pain analog to hemoglobin? And the answer is no. It's a self-report. It's a condition, and therefore we often struggle with how do we assess pain in the absence of the typical signs of pain that would be present in an adult. However, pain assessment is essential and possible. The other question, of course, is related to diagnosis. If time is important, then we need to be careful that we don't just include dimensions of symptom intensity, duration, and frequency, but we also think about what else is going on and how do we assess function. We often faced with using really good drugs, but because of pharmacologic issues related to drug interactions or metabolism, good drugs sometimes fail. And it's not because we've chosen the wrong drugs, it's just because we haven't considered the entire biologic or metabolic context in which the drugs are used. And finally, it's really important to understand that our ability to treat pain very much embedded in the clinical context in which we deliver care. So the clinical encounter is well understood to have a meaningful role either in providing an agency or capacity for benefit, or actually detracting from that. And we have to recognize that perhaps a mismatch between caregiving environment, the words we use, and expectations of the child, family, and clinicians can sometimes detract from effective pain management.
I'm so excited to talk to you about the clinical encounter, and you've raised a lot of points that have come up in my research. Let's talk about the clinical encounter. What do we know about what drives this in managing pain in children?
Well, typically we think of a symptom like pain, and we think, okay, well, if we just look at doing lots of tests and taking a good history and physical exam, we're going to figure this out, and we're going to go from the symptom to the cause to the cure. And as you can see, it's typically, and just for the sake of this conversation, I've made this a little bit oversimplified, but essentially we're thinking of it as a straight line. But, you know, in reality, we're often finding ourselves on a very windy road, and the road is filled with lots of tests, lots of consults, investigations, treatment that sometimes works and sometimes doesn't work, and finally we end up with a sense of anxiety that maybe we haven't quite got to the bottom of it, that leads to some very poor sense of direction, hopelessness, and it only compounds our complex pain, suffering, and disability that exists for both the child, the family, and I think to some degree the clinicians also experience this as the highway unfolds in front of us. Well, as it turns out, the more tests you do, the more likely you are to find something that really doesn't exist, and essentially you find yourself in the universe of negatives. And the universe of negatives is that there's no limit to how many things don't exist. The search for things that don't exist is infinite. And the engine that drives this causal quest is really the disbelief-belief cascade, where you believe that something's going to happen and then it doesn't make a difference, and that leads to disbelief, that then leads to more belief, and in a sense this whole journey is generated by this vicious cycle. It's a self-perpetuating cycle. It's expensive, it's stressful for families, and it really is a painful journey for all.
Yeah. This is a major challenge that we found that children with chronic pain, their parents and clinicians face, is understanding the cause of the pain in this journey that they're on. And it's understandable because the nature of chronic pain, a chronic pain diagnosis, is complex. It's challenging to explain and understand. Many patients with chronic pain don't receive a diagnosis that explains an underlying pathology or disease state for their pain, like arthritis or cancer, and they're simply given a diagnosis of chronic pain. So uncertainty is a major part of the experience of having chronic pain that isn't linked to pathology, and yet it's this elephant in the room. It's something that we're not talking about.
Wow, this is really interesting. Tell us, what do you know about diagnostic uncertainty?
Yeah. So diagnostic uncertainty is defined as a subjective perception of an inability to provide an accurate explanation of the patient's health problem. And research among adults suggests that over 40% of patients with chronic back pain report diagnostic uncertainty. They report having received a diagnosis, but also that they believe there's something else undetected and serious causing their pain. And among adults, we know that diagnostic uncertainty is linked to worse pain outcomes, mental health, and emotional distress. But our understanding of diagnostic uncertainty among youth is less clear. What we do know is that many children with chronic pain perceive the explanations provided by physicians for their pain as false and have difficulty buying into a diagnosis of chronic pain. We also know that even after a chronic pain diagnosis has been provided, many parents of children with chronic pain struggle to accept a lack of explanation for their child's pain and continue to search for another diagnosis. Abby Jordan and colleagues have beautifully described parents' sense of being in limbo, this state of uncertainty in which they're unable to move forward in daily life and are really unsure about the future. And this uncertainty is tied to parental guilt, helplessness, and distress. And in another study, Melanie Knoll and colleagues found that nearly 40% of parents reported an unresolved diagnostic orientation towards their child's chronic pain, so not accepting or buying into the diagnosis. And this suggests that the prevalence of diagnostic uncertainty in pediatric chronic pain might be similar to the adult literature. But just recently, a topical review has called for research in the area of diagnostic uncertainty among youth with chronic pain. So diagnostic uncertainty in this context is really only just beginning to be investigated, but we think it's fundamental to the child and parent experience of chronic pain, their adjustment and acceptance of a diagnosis, and their responsiveness to intervention as well.
Alex, tell us what you've learned about diagnostic uncertainty among youth with chronic pain.
Yeah, well, our pain and mental health in youth study, we've asked 180 youth with chronic pain and their parents to respond yes or no to 3 statements regarding diagnostic uncertainty. These are all youth who have been identified as having chronic pain without an underlying disease by a provider in a tertiary level chronic pain clinic. And I'm going to share the results of those 3 statements, or 3 diagnostic uncertainty questions with you in a moment. But we also interviewed 20 of these youth and one of their parents to elicit a narrative about their journey, with specific emphasis on what they remember about receiving a diagnosis. So a little bit later, I'll share the qualitative results of these interviews, which was published in the Journal of Pain. And first, I'll share these 3 quantitative questions. The first statement was, I have been given a clear label or diagnosis for my or my child's chronic pain. And what we found was that about 45% of parents and children say they have been given a clear diagnosis for their pain, but about 55% say they haven't. And remember, these are all children in a tertiary level chronic pain clinic. About 60% of parents and 80% of children say they have not been given a clear explanation for their child's chronic pain. And arguably, the most interesting question and the real question that digs into diagnostic uncertainty is, I think there's something else happening with my or my child's chronic pain, which doctors have not found out about yet. About 1/3 of parents and children believe that there's something else happening, something else going on that hasn't been found. So even after receiving a chronic pain diagnosis, many families are still uncertain and think that there's something else causing the pain. So this is really interesting data, but we believe that diagnostic uncertainty isn't easily quantified, that it's very nuanced. So to fully understand diagnostic uncertainty, we interviewed 20 youth and their parents about their pain journey. We asked parents and children separately, where did this all start? Where are you now on your journey? Where do you see this going? And what do you remember about receiving a diagnosis? And what do you make of that diagnosis? So I'll share some of the qualitative results with you. The most prominent theme among youth and parents was what we call the function of a diagnosis. Many youth and their parents really struggled with the meaning of their diagnosis. The label wasn't enough, and the diagnosis itself wasn't helpful in terms of understanding their pain. Many shared this sentiment of Lauren's mom here, that the diagnosis tells us nothing. Parents and youth expressed needing further explanation beyond that label, about the causal mechanisms underlying the pain. So Isabel here says she has anxiety surrounding her pain because she doesn't know why this is happening. And she says, I know what a migraine is, but I don't know why I have them. So the diagnosis of chronic pain itself elicited uncertainty and was perceived, sometimes perceived by parents as this diagnosis given in the absence of an actual understanding of the cause of the pain, in an absence of the why. And parents sometimes described a chronic pain diagnosis as this catch-all diagnosis or a default diagnosis. So really a diagnosis of exclusion, which wasn't helpful in terms of actually understanding the pain. Throughout the narratives, parents and youth sought the right diagnosis. And what would be the right diagnosis? Well, it seemed to be a diagnosis that would fit the parent and youth's perception of the cause of the pain. For many families, the right diagnosis would have this pharmacological solution for the pain, so this silver bullet cure. And when the pharmacological solution didn't work, or when a non-pharmacological solution was suggested, this led parents and children to question whether whether chronic pain was the right diagnosis, and it led parents and children to believe that doctors really didn't understand what was causing the pain, and really fueled their diagnostic uncertainty. The second theme that was generated, we call haunted by something missing. And we found that through these narratives, that uncertainty about the diagnosis fueled this worry that something has been missed, and that what was being missed was serious, sinister, and potentially life-threatening. And throughout the interviews, youth sometimes referred to these inklings that something was being missed. So Nicole here says that she has this inkling that there is something in her brain that might not be good, and that would have a long-lasting impact. These beliefs that something could be missing were intricately tied to their experiences with clinicians and the medical system as a whole throughout their entire diagnostic journey. For some parents, the experiences impacting their current uncertainty now with this chronic pain diagnosis stemmed from experiences back when their child was an infant. So James's mother here talks about how she shoulders this guilt of having missed reflux that caused kidney damage earlier in her son's childhood because she had accepted an inaccurate clinical diagnosis. So this is a mom of a 15-year-old who's linking her uncertainty now about this chronic pain diagnosis to a previous experience over a decade ago when something was missed. And you can imagine that this mom probably brings this experience with her into every clinical encounter, and it impacts her buy-in to diagnosis and to treatment. And yet we don't assess this. We don't assess the journey often in the clinical encounter. Related to this, negative test results didn't provide relief from these fears or worries that something was being missed. Parents and youth didn't want tests that continued to exclude diagnoses. They wanted tests to prove a physical diagnosis, especially one that would be curable and that would have a treatment plan. So Julia here is saying that she's had all these tests. She's had blood tests and CAT scans, and these tests say that everything is fine. But how can everything be fine when she still is experiencing so much pain? She says that, she knew everything wasn't fine because it's not normal to have so many headaches. And ultimately, a continued search for this alternative or right diagnosis continued. And we know that this happens. We know that many youth go from doctor to doctor in this search because each new test or physician holds hope of achieving the ultimate goal of stopping the pain and finding the cause. And even if this means invasive surgical procedures for some. So this really shows the length that families are willing to go to find the cause. And Emily's mother here expresses that she doesn't want her child to have an invasive surgical procedure, but she hopes that this will help her move forward, that this will end her search. And unfortunately, we know that for many families, this final validation that Emily's mother talks about is always just beyond grasp. Of course, it possibly goes without saying that all these experiences impacted and were impacted by families' trust in the medical system. When youth felt that diagnoses provided by clinicians were not credible and not an accurate label for their pain, they felt that they hadn't been seen, heard, or understood, and they really felt invalidated. It left them unable to buy in to the diagnosis, and it impacted their confidence and trust in clinicians' ability to help them. And some youth, like Catherine here, expressed doubts in clinicians' understanding of their condition, so perceiving that clinicians were uncertain themselves about the diagnosis.
Alex, this is really fascinating findings. But as I hear you talk, I'm beginning to wonder whether clinicians themselves also play a role in either generating or reducing diagnostic uncertainty. What do you know about clinicians' role in this setting?
Absolutely. I think this is a critically important question because, like we've talked about, we see the clinical encounter as this major factor in diagnostic uncertainty. And we recognize that this is really hard for clinicians too. So I have some other data to share with you today, and that is data from my wonderful colleague Abby Jordan at the University of Bath, who conducted individual semi-structured interviews with clinicians. So this is data from the UK. She interviewed 16 pediatricians who assess and or treat youth who experience complex chronic pain. And we think it's really critical to understand diagnostic uncertainty from the perspectives of pediatricians because they're often the first clinicians youth consult when they start to develop a pain problem, and they make up the majority of referrals to a pain program. So we know clinicians struggle with diagnostic uncertainty as well. And what was evident from these interviews is that uncertainty is really inherent to the role of treating youth with chronic pain. So throughout these interviews, clinicians often referred to this metaphor of drawing a line in the sand. And clinicians use this metaphor to describe the process of deciding when to stop testing. This line in the sand metaphor implies a clear limit. But in reality, the line was influenced by a variety of complex factors. It was influenced by clinicians' own uncertainty and their own need for reassurance, their own pain training, the severity of the child's symptoms, and the family's anxiety and beliefs about the diagnosis and needing to align with families. So some clinicians recognize the importance of the child's journey with the medical system. So for example, families who had seen multiple clinicians and received differing explanations for their pain were seen to have more mistrust in the medical system. And this was really noted as a barrier to family and youth buy-in to diagnosis and treatment. And importantly, that line in the sand was described to change based on this perceived mistrust or lack of buy-in, and really needing to align with the family. I'll share another piece of this data, and that's that interestingly, there was differing beliefs about clinicians, among clinicians about reassurance. So while some clinicians recognized that tests were not always reassuring, many clinicians saw tests as reassuring and even ordered more tests for the more anxious and uncertain families. So even clinicians who recognize tests as not always reassuring noted that their decisions about ordering diagnostic tests to reassure was on a patient-by-patient basis. So this is really important because we know that unnecessary testing increases healthcare expenditures and carries risks of false positives and iatrogenic injury. But also continuous negative test results not only delay treatment, but we've found that they also fuel diagnostic uncertainty and fears that something is still being missed with these families. So where pediatricians reported ordering further tests to alleviate uncertainty for families around a diagnosis of chronic pain, this may actually have the unintended opposite effect.
Well, Alex, that is such a powerful message. Can you summarize what you've learned from your work in a way that will be helpful to clinicians?
Yeah, I think I've thought a lot about this, and I think there's some key messages in the narratives of these families that are really most important for clinicians to be aware of. And the first one is that a label is not enough, that youth and parents need more of an explanation. They need to know the meaning of their pain, where this began, why they have it, in order to buy in, engage in treatment, and to really feel supported. And the second is that negative test results do not provide relief for families. And in fact, they may continue to fuel a search for the right diagnosis or cause of the pain. And really the implications of this search and of diagnostic uncertainty are that meanwhile, not only are youth not engaging in treatment, but they're also undergoing invasive procedures that have the potential for harm. And finally, the past experiences are important. The journey, the story, the narrative matters. It has important impacts on the family's trust in the medical system and will impact their buy-in to a chronic pain diagnosis. And this might involve more than their journey with this pain problem. It may involve other previous experiences. Really, it could involve any previous experiences with the medical system or even that of a close friend or family member. So this is really important. But this is what we've gathered from the research. And Tim, I'm so curious because you sit with these families every day. What do you see as being useful in your clinical practice? What do you already do as a clinician to move beyond diagnostic uncertainty? Because the obvious question left here is, what do we do about diagnostic uncertainty?
Your findings give incredibly powerful messages and should remind us that at the very outset, we need to recognize that diagnostic uncertainty is a critical stumbling block that often paralyzes care and our ability to function as clinicians. And I think that the work you've presented and the work you've done highlights that point in acknowledging that it exists, that there's an elephant in the room. And how do we bring that out into the open then? How do we say to families, I think one of the engines that's driving your pain and suffering, and we can use whatever words, is really the critical task that we have as clinicians. So that brings up this whole question of how do you actually assess uncertainty? You've mentioned research tools Are they available to us in the clinical setting? I'm not sure, so the pitch that I'd like to make is, let's see if we can figure out how to harness these findings to develop a clinical approach to addressing and scaling back diagnosis uncertainty, and maybe some of the lessons that you've talked about could help us. But maybe at a simple level, it's really just the language we use. We need to identify fears. We need to acknowledge that it's there. But even more important than acknowledging it is to actually sort of tease apart what is scaffolding the uncertainty. What is holding this up? And you've talked about the power of beliefs. I believe it's very important to understand the origin story of the pain and how does a child and family explain it? How do past encounters add to that story? And how does it contribute to uncertainty? And in understanding that journey, we're able to access a particular life experience that might be unique to that child. The second part in unpacking uncertainty that I think we can glean from your findings and from my experiences, the value of the therapeutic encounter. And in fact, all of what we are talking about here is embedded in the words we use, the body language we have, and the type of clinical encounter that we develop. Are we doing it in a comfortable setting? Are we doing it in a time-limited setting? Is there a sense of rush? And are we actually prepared to have that encounter? So, for example, can we actually say convincingly, I have done a chart biopsy. I can confidently say there are no biomarkers of troubling disease, acknowledging that there's a bad symptom, but it doesn't mean that something bad is going on. These are all incredibly important messages to get across, and the language we use and the intention that we give in delivering that news can address diagnostic uncertainty. You know, normally we think of pain as something really bad that's happening, and there's often a sense that the disease can be found. But I think that reframing it in a metaphorical sense, and this is a lesson that my friend and colleague Neil Schechter has shared with me, is that the use of metaphor can be a very powerful tool in being able to change the narrative. So I like to use the metaphor of the car alarm at 3 o'clock in the morning. Here we have a device that's supposed to be designed for health and safety, and yet sometimes at 3 o'clock in the morning it goes off. Looking for the source or the cause for that 3 o'clock in the morning car alarm may not be helpful, but trying to shut it off should be the goal, and improving both the function of the car and getting the neighborhood back to sleep should be the focus. I think it's also really important to focus on what kind of symptom reduction and improved function can we provide, and in that way we can move the conversation away from what is to what can become, and in that sense, harness both mind and body physical exercise can be very helpful in showing that there is some capacity for healthful living as opposed to painful living. In that way, we can probably develop a treatment plan that should emphasize the dual roles of both the child, youth, and family as active participants in improving pain and reducing suffering. I also believe that sometimes the use of medications can lead to unwanted side effects, and it also heightens the sense of uncertainty. Good drugs should work, they don't work, what's that all about? So removing drugs can be a very effective way of eliminating that as a source for uncertainty. I also believe that time perspective can be very helpful. So, I often joke that I'm not the quick fix doctor, and when I go to the quick fix clinic, that's somewhere else. And the long-term perspective is incredibly important. Obviously we can't predict sort of where this turns out, but we tend to think if you put a treatment in place, then in a week you're going to have a benefit. And that doesn't really work here. So in the short term, that only leads to more disbelief and uncertainty. So taking a long-term perspective can be a very helpful way of diffusing that whole time question. And finally, I think it's really important to emphasize that no matter what the outcome is, that we're going to be working on developing a toolbox for the child and family that's going to be filled with tools that can help in coping with pain and stress across the entire lifespan. And so there can be a very hopeful message. And I think in that hopeful message, you can move away from the dark cloud that diagnostic uncertainty often leaves families with, and certainly leaves clinicians with.
Yeah, absolutely. And you're really touching on sort of the messaging from clinicians, and diagnostic uncertainty in general is really this elephant in the room. It's not being talked about between the clinician and the family often in the clinical encounter. And we're now investigating these different factors in the clinical encounter when pain is explained or chronic pain diagnosis is provided that might influence parents and youth experience of diagnostic uncertainty. But meanwhile, we know that youth and parents are experiencing this, and you see them every day. And we would agree that, or I would agree that it needs to be addressed and assessed in the clinical encounter. That asking about the journey is important, that the messaging being sent from the clinician is important, asking about the origin story, what you said about how the child or parent is experiencing this, and what their origin story is, and acknowledging that uncertainty is a possibility for families, that it's possibly on their minds, whether or not it's being assessed. So bringing it out in the open, and in that way, it could be used in the clinical encounter to help shape that pain explanation rather than being this silent barrier in the clinical encounter. Absolutely. So with that, we like to say a really big thank you to our funders and supporters. I'd like to say a big thank you before we open it up to questions. A big thank you to my truly incredible mentors on this research, Drs. Melanie Knoll and Abby Jordan. And I'd like to recognize and say thank you to all the families who shared their stories with us. It's been very meaningful work to do, and I hope it's been meaningful for you all today. I was happy to be able to share their voices with you. Thank you, Tim, for joining me in this conversation and sharing your valuable perspective as a clinician who sees these youth every day. And thank you, Children's Healthcare Canada, for allowing us to share this work today.
Thank you, Alex.
Thank you both. We've got a couple of questions here, if you're okay to take a couple.
Excellent, yes.
One is, to your knowledge, has the impact of diagnostic uncertainty on triage decisions to interdisciplinary chronic pain programs been explored? By that she means related to delaying access to interdisciplinary treatment.
Mm-hmm. I am not aware of research on triage decisions in particular. Certainly, so in our research with interviewing pediatricians, we know that many families, and Tim, I'm sure you can comment on this as well, the families that before they make it to in a pain clinic, they've seen many physicians on this journey, and that certainly that it's this journey of uncertainty that impacts how they show up in a pain clinic and how they buy into a diagnosis by the time when they finally arrive there.
Thank you.
Yeah, I would agree, and it'd be really interesting to look at whether there's some empiric evidence that supports that a prolonged journey, multiple investigations, multiple consults, going from primary to quaternary care, is positively associated with more uncertainty. I would suspect it would be. The only problem with that is that inherent to the definition of chronic pain is time, and time generates all of those things, those tests, uncertainty, and more tests. So it's a bit of an issue of confounding by indication. The actual thing that we want to study is very embedded in the actual definition of the thing that we want to study. So it's a bit of it's complex, but I think that those things are related.
Thank you both. Another question is, what advice do you have for clinicians to support families and parents in uncertain diagnosis and help them return to function and back to routine?
Mm-hmm. Tim, I think this is a great question for you, but I think I would say in terms of addressing uncertainty, I think it needs to be talked about, and that assessing where the family is at in this and acknowledging possibly that uncertainty is on their mind is important.
Wonderful.
Absolutely. I would say that that it needs to be an inherent part of any chronic complex pain consult. But I think it also needs to be paired with a plan of how to move beyond it, because I think while there's therapeutic value in the conversation, it also can be a showstopper. And that's where I take a sort of a functional symptom reduction approach guided by the child and family's goals. So if the goal is to return to figure skating, then that's exactly what we're going to work on. So we're going to deal with the journey that's led up to the clinical encounter, and the diagnostic uncertainty is a part of that. But at the same time, need to pair that with a plan for something that will probably yield some change to the equilibrium. Because in a sense, diagnostic uncertainty can be a barrier to, not in a sense, it actually can be the barrier to improved function and symptom reduction.
Absolutely.
Thank you. You mentioned the challenge of assessing chronic pain in children with developmental disabilities and delays, whether they be nonverbal or have a cognitive delay. What assessment tools do you suggest to assess pain in those particular children?
Yeah, that's an important question. Well, there are standardized tools, depends on the context. So typically, the non-communicating checklist has an important role to play in being able to identify the variations in expression of pain, whether it's verbal or nonverbal. The FLAC can be quite helpful, but typically with motor impairments, the lake assessment is sometimes constrained. And so you get an erroneous result. The triple T has also been used in it's highly specific to a particular child. And then at the end of the day, I truly believe that experienced caregivers are an incredibly valuable source for what constitutes pain. And so we can't, we should never discount the importance of caregivers, experienced caregivers who can help us tease apart pain from other emotions.
Thank you, Tim. Another question says, and I think this one's directed mainly for Alex, but possibly for both of you. In your qualitative work, did you discover any differences between parent and child opinions or responses?
That's a really excellent question. What I will say is that, so we had these parent-child dyads and we interviewed them separately. And what came out in terms of the themes for parents and children were similar. The same themes came up for parents and children, but they weren't necessarily, the parent-child dyads themselves weren't necessarily on the same page. So I think this is a really important question, and important for clinicians to know that the parent or child in your office may differ in their levels of uncertainty or the severity of the uncertainty that they're experiencing, and that the parent and youth are not necessarily equal in the levels of uncertainty or how they're buying in or conceptualizing the diagnosis, for sure.
Another comment with a question is, some pain programs seem to believe that treatment for pain, especially through PT and OT, should not focus on the pain and severity itself, and that clinicians should avoid speaking of pain with children during treatment. Do you know of any research behind this philosophy, as it seems it might fuel diagnostic uncertainty?
Tim, I don't
Alex.
do you have anything about that.
Yeah, no, I'm not aware of
Mm-hmm.
I'm not aware of that literature.
Okay.
I'm not aware of it either. Yeah.
And there's a number of questions related to the specific tools in the toolbox that you mentioned. Are you able to elaborate on describing the tools that you have available?
Oh, so I presume this question relates to the last slide, which is your toolbox will be filled. So, when we talk about managing pain, chronic complex pain, we talk about self-management skills that includes both the mind, the body, exercise, sleep, eating, social engagement, school. So each of these can be improved with learning skills that relate to self-regulation or stress reduction through mindfulness, a daily exercise program. And all of these are tools for essentially for healthy living. And so beyond just managing pain and moving beyond chronic pain, these tools can be used across the whole lifespan for managing future pain, stress, and improving daily healthful function.
Thank you. And one last question. How can folks like daily workers like PSWs support families and patients during daily care?
Mm.
I'm not sure about the abbreviation. Can you just remind me what the abbreviation?
Personal support workers. So folks involved with the support for the family in the home, for example.
Sorry, can you repeat the question again?
So the question was, how can daily workers like PSWs support family and patients during daily care? And I assume that some of the responses to that relate to the tools that you were just referring to, that the folks in the home can support the family by directing them to the appropriate information and tools, suggestions of alternative pain management approaches at work. They can look at folks like SCIP to look for the best available evidence. Are there any particular specific advice you have to other allied support folks in the lives?
This is a very important question, which gets to this whole question of the role of communication in managing chronic complex pain. So we think about it as an iterative process that has to engage both the child, family, and community. And it's sometimes very valuable to have community professionals come and join either by Skype, telephone, or actually in the clinic, because getting their perspective and sharing the treatment plan and developing a treatment plan in conjunction with them is incredibly valuable. So it's not just the tools, but it's the ongoing communication between teams that can actually keep the process moving. And in that sense, and maybe that needs to be added to the take-home messages that when in doubt, book a follow-up appointment and keep the communication open between community and families and clinicians.
Wonderful. Thank you. That's the end of the questions we have, unless others are ready to type in. But right now, we've been through the questions that folks in the audience have asked. And I want to thank you so much for speaking with us today, both you, Alex, and Tim. It's been very helpful. And I just want to let others know that Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. It's great if you can watch live, as your questions and comments really enrich the discussion, as you could see from here. But if you can't watch live, the recordings of these sessions are made available after the effect on our Knowledge Exchange Network. We're also excited about the next coming webinar on February 26th, when we'll hear from Polina Kosovera and Olivia Oleneski from Holland Bloorview, for their Dear Everybody campaign. Holland Bloorview Rehab Hospital is Canada's preeminent children's rehab hospital and a global leader in childhood disability research. And the Dear Everybody campaign is a public awareness initiative that aims to eliminate disability stigma and promote inclusion in many areas of life, including schools and the community. If you haven't already done so, please sign up for our Spark Live newsletter to stay up to date on all of our activities and events. So thanks again for joining us today. Thanks to Alexandra and Tim and folks at SCIP for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye-bye, everyone.